So someone asked us to talk about acetazolamide, also known as Diamox. So acetazolamide we use in neuro-ophthalmology for idiopathic intracranial hypertension. And idiopathic intracranial hypertension is idiopathic and it causes intracranial hypertension, which means increased intracranial pressure. And so this disorder, IIH, can be treated medically with both acetazolamide and weight loss, and if necessary, surgery, either a shunting procedure, stenting, or a sheath fenestration. We're only going to talk about acetazolamide medical therapy. And what you need to know is the idiopathic intracranial hypertension treatment trial showed that acetazolamide is effective medical therapy, both for lowering the intracranial pressure and for treating the visual field defect of moderate idiopathic intracranial hypertension related vision loss from papillary edema. So there's no question, based on the randomized controlled clinical trial, that acetazolamide works for IIH and that it is our first line medical therapy in addition to weight loss for IIH. As you know, most of these patients who have IIH are young, overweight females, and so weight loss is our preferred treatment, but Diamox, acetazolamide, is our medical therapy. And so I normally start at a dosage of 500 milligrams twice a day, but in the IIHTT, we know that we can go to as high as 2 grams all the way up to 4 grams of Diamox. And normally the rate limiting step is the side effects. The side effects that were seen in the trial, but also in my patients, are the usual side effects of acetazolamide, which include paresthesias and tingling in the hands and the feet, a metallic taste in the mouth, especially for carbonated beverages. Some patients feel fatigue afterwards. It's not a very strong diuretic, so they don't usually complain about going to the bathroom all the time. However, it is one of the known side effects. Now, you need to know that the major thing that we're worried about with acetazolamide is the metabolic acidosis that follows. And the reason is acetazolamide is a carbonic anhydrase inhibitor. And what that means is it is an inhibitor of removal of the water, anhydrase, from carbonic acid. And so normally when you have carbonic acid, we can break this carbonic acid down using the carbonic anhydrase to remove the water and generate CO2. So water and CO2 are easy for our bodies to get rid of. We can breathe off CO2 and we can dump out the water in our urine. And so these two products are a good thing to have as byproducts when we're breaking down H2CO3. However, if you block the carbonic anhydrase, because you're giving a carbonic anhydrase inhibitor, this thing will dissociate into its ionic components, which are H plus and CO3 minus. And so when we have H plus and HC3O minus, this will cause problems in the kidney. So when you're dumping this out into your urine, it will cause the urine to be alkalotic. So alkaluria will result from the dumping of the sodium bicarb into your urine, and that will lead to a metabolic acidosis. So if we're dumping the bicarb, we're going to be increasing the acid-base balance, and metabolic acidosis will result. In addition, in your kidney, we have very few ways of exchanging these ions, and a plus has to change with a plus. And so in the kidney, the exchange pump is with sodium. But this sodium also exchanges with potassium. And so when we are trying to keep the sodium, we're exchanging with the hydrogen, we might be driving potassium out into the urine. And that's why when you're dealing with acetazolamide and its metabolic acidosis, we might end up with a hypokalemia. And that is a potentially life-threatening electrolyte imbalance. In addition, if we're dumping the sodium bicarb, the chloride has to exchange. And so we might be having a hyperchloremic, hypokalemic metabolic acidosis. And that can make patients feel bad, but it can also cause potentially life-threatening problems. And so we want to be afraid about acetazolamide in certain conditions, but especially if they're symptomatic from their metabolic acidosis or if they don't actually have idiopathic intracranial hypertension. And the scenario we're most worried about is patients who have cryptococcal meningitis. So in cryptococcal meningitis, they have intracranial hypertension, but it's not idiopathic. And if you give acetazolamide to that person, it was shown in a randomized controlled clinical trial that acetazolamide not only didn't help the cryptococcal meningitis people, it was more likely to produce an adverse outcome, and that adverse outcome was death. So we give acetazolamide to idiopathic intracranial hypertension, but you should use it with caution in other causes of intracranial hypertension, especially if they have metabolic acidosis, and probably you shouldn't give it for cryptococcal meningitis, even if their intracranial pressure is quite high, because the patient's died. And in those cases, we use serial lumbar punctures or a lumbar drain rather than the traditional medical therapy of acetazolamide. So, in summary, you should use acetazolamide for IIH. It's our first line. I start at 500 milligrams twice a day. We can go up to 2 to 4 grams. And beware the metabolic acidosis, because it is a carbonic anhydrase inhibitor.